Welcome, and thank you all for coming to share this very important discussion. This forum is being presented by the Anti-Racism Action Group of the Community Church of New York, Unitarian University, and is a committee of the church. For those who do not know me, my name is Rose Creighton. I am the chairperson of the committee, and I am honored to be working toward racial and human justice with this very small and dynamic group of members, all who are very dedicated and committed. The members of the committee are, needless to say, Marianne Roncoli, our speaker. The other members of the group are Faye Bennett Lloyd, Patty Paris, Ellen Rader, and David Strawn. Did I leave out anyone? And of course, Esther is our staff liaison, and she's a participant in the group as well and very helpful to us. We have been working together since the beginning of the COVID pandemic in an effort to arm ourselves with knowledge and to share that information in forums such as one we're having today. As we all know, the internet provides excellent information. And even though it provides us excellent information, there's a downside to it. We get a lot of misinformation, misrepresentations, and actual outright blatant lies. So and these negatives are detrimental to our striving for a true democracy, which we do not have at this point. So we agree that we have a plutocracy, and we look around us and see what's going on today. We know that it is ruled by the ruling class and the wealthy. I wasn't going to talk about this, but I can't help but do it because I'm thinking about Gaza and the fact that the people are out in the streets across the world actually protesting, but our government is sending our money to continue this destruction and killing. But that's enough, that's an aside. See, I'm having trouble here. Okay, so we'll have this forum is also to try to dispel some of those facts and misrepresentations around healthcare. And in that respect, we are going to hear from our speaker, Dr. Roncoli. And I will give you a little bit about her. Right. Marianne Roncoli is a retired pediatric nurse practitioner who practiced at Bellevue Hospital and served as a clinical assistant professor at New York University School of Nursing. She has a doctorate in nursing from NYU and was awarded a Robert Wood Johnson postdoctoral fellowship in perinatal nursing at the University of Pennsylvania and served as director of perinatal nursing at the hospital. She's also had dual appointments in education and clinical practice throughout her career. Dr. Roncoli.
Okay, thank you, Rose, for the introduction. Can everybody hear me? Yes? Okay. Let me just, I'm going to put this down here. You see the title of the program, Systemic Racism and Healthcare Access, Follow the Money. That is basically what I'm going to be presenting to you today. And then after this, there's two bookends here. One is my bookend of explaining how the healthcare system works and how it is because of how it's funded. And at the very end of this program, we're going to have David Stratham speak also to this very fact of how money directs our care. Oops, sorry, okay.
Marianne, Marianne, before you begin,
yes.
When will you be taking questions?
I will take them at the end. And people can put them into the chat. I think I'll work from there. Is that okay? Is that all right with you?
That works with me. Just wanted to make sure everyone was aware.
Okay. First thing we're going to do this in three ways. First, we're going to talk about the healthcare system as it currently exists, not necessarily the way we want it to exist, but the way it does exist. And then we're also going to look how systemic racism interfaces with this healthcare system. And then at the very end, we're going to look at the political climate that we're working with right now regarding healthcare delivery. For your benefit, where did I get all this information from? You can see here, this is a link to all the resources that I use. I invite you to access this if you can. If you're having trouble getting a hold of it, fine. This is basically telling you every one of the links that I address in this program, and it's available for you as a reference. Let me see how, okay, there we go. The first thing to keep in mind about the healthcare, so this is the whole program in this slide. Patient care is based on payment for services, not on the healthcare needs of patients. Important to keep that point. That's the driving concept of this presentation. The availability and quality of care depends upon race, ethnicity, culture, and social class. That's what this program is all about. A brief history of the healthcare system since 1965 to the present illustrates how we are following the money. First of all, in 1965, Medicare and Medicaid was established during the Lyndon Johnson administration. And in that plan, physicians and hospitals determined the payment for healthcare. They provided health, they submitted a bill based on reasonable and necessary charges, and the government paid it. Well, that system started to balloon out of control when healthcare costs skyrocketed. The Social Security Reform Act in 1983 changed that payment system. Enter Ronald Reagan. The Center for Medicare and Medicaid Services now, we're going to determine the payment based upon the patient's diagnosis. This was a prospective payment system. In other words, based upon what the patient was diagnosed at the time of admission, that was going to determine how much money the hospital was going to get, or a doctor was going to get, or a home care agency was going to get. It was based upon a diagnostic related grouping. This is an example of one of them. There are 15,000 diagnostic related groupings in a very, very large booklet. And it is somebody's job to connect the diagnosis and all its subdiagnoses to the patient's record and combine those two things together. And on the basis of that, the hospital admission, the doctor's visit, or the home care visit or source of care is determined, the price is determined. Now, this system depends upon some interesting little side trips here. Given that the government is prospectively paying a hospital for a type of visit, what that means is they're getting a pile of money, and the hospital is at liberty to spend it any way they want. And if they choose to spend more money caring for the patient than they're being reimbursed, they eat the cost. If they spend less money than they're being reimbursed, they get to keep the difference. So now, do you get some concept now as to how it is that you go into the hospital today for a major operative procedure and you're out of the hospital in 3 days? Because they've worked it out today that you do not need to be in a hospital that long, and the hospital doesn't make any money if you're there. There's safeguards built into the system. If you are discharged from the hospital and then go back in the hospital right after discharge, that means that you discharge the patient too early and you're not going to get paid. If while the patient is in the hospital, they develop a complication, such as a bed sore, or they develop an infection, that will affect your reimbursement. So there's guardrails built into the system, but basically the hospital is paid upfront. The doctor is paid upfront. The home care agency is paid upfront based upon the patient's diagnosis. Let's go a little bit further. In 1996, the Children's Health Insurance Program was, the Medicaid expanded for the Children's Health Insurance Program known as SCIP. It was designed to address the coverage gap. Parents who made too much money to qualify for Medicaid and not enough money to pay for insurance for their children. Children were getting sick, they weren't getting immunized, they were going to hospitals unnecessarily, and something had to be done. And Congress acted in this regard so that we do have this program, which is very effective and very good. Then we had the Medicare Modernization Act of 2003. We discovered, as drug prices started to skyrocket out of control, we discovered that, wait a minute, Medicare's not paying for drugs. So the elder population got very concerned about this, and at that point, George W. Bush was the president at that time, and his administration came up with this scheme called the donut hole. The first reaction to the donut hole was to start laughing hysterically. After the laughter subsided, we came to the conclusion, and we figured out how this whole thing worked. There was this hole in the middle, where whatever drugs you had to pick up the cost for them, and there was a certain category of them that were relatively expensive, and you had to pay upwards of maybe $5,000 a year out of your own pocket. But once you reached that limit, you moved into the Krispy Kreme section of the donut, where you didn't have to pay for anything anymore. Well, this turned out to be a very difficult system to manage, and fortunately, the Inflation Reduction Act of 2023 is eliminating this quote-unquote donut hole in 2025. Then we have the Affordable Care Act of 2015, or also known as Obamacare. Why did we finally had something close to what we would think of as national health. Wait a minute, why didn't we call this the Patient Care Act or the Comprehensive Care Act? No, we called it the Affordable Care Act. So it's still all about the money. That was the most important thing that people had to know. Was it affordable or wasn't it? And that was 2015. And there we are today. This is where healthcare is today, based upon, it's all about how much it costs. How does this, what are the benefits of the act? What do you get for it? How does it work? First of all, you earn premium tax credits that is calculated on your income level. You purchase insurance from federal or state marketplaces, and you do all of this online. This program, the Affordable Care Act, also expanded Medicaid program for adults at 135% of the federal poverty level. Here's the caveat. Medicaid is also controlled by the states, so states had the option to opt out of this benefit. It also included support for innovation in the system. If you came up, it was basically rewarding creative approaches to health, and it was built into the system, and many people have taken advantage of it. You can see the piece on the other side there. If you didn't have any insurance, you either didn't pay for it, you didn't qualify for anything, it would cost you, without premium tax credits, if you purchased insurance yourself, it would cost between $9,000 and $18,000 a year. What is a premium tax credit? This is a credit that's available for people who buy marketplace coverage and whose income is at least as high as the federal poverty level. And it's based on whether you're an individual, whether you're a family, and that's how you determine this tax credit. For an income for at least $14,000 at 2024, for a family of 4 to 30,000, you calculate this tax credit. You think, well, I'm going to declare it on my income tax, the cost of health care. of the healthcare policy that I choose. I'm going to declare that on my income tax, or I can subtract that amount of tax credit from my monthly premium. You have a choice of how you're going to handle it. You don't have to wait until tax day to do this. Individuals and families can access marketplace subsidy calculator. I put this in here. It's sort of like it's available for people. They can help themselves to figure it out. I also want to address you to the source of this information. It's from the Kaiser Family Foundation. This is an independent source for health policy, research, polling, and news. It is a progressive website. So you're going to get a very open and progressive view of healthcare. Everything you may want to know about it is located in this particular organization. Okay, we're moving along here. Where are we? Okay. What is the healthcare marketplace? This is where you're going to see variations in the country and how we deal with things. It is a gateway for individuals, families, and small businesses to apply. It is not available. The Affordable Care Act is not available if you have employee health insurance, if you're working. It's only for people who don't have insurance for whatever reason. It's being made available to you. Insurers all get together on this marketplace and compete based on costs and need. So they can compete to keep their rates down. It also is, put weekdays there because that's relevant to the state of New York. You have these exchanges where you purchase insurance. You have a state exchange and a federal exchange. And it takes a long time to try to figure out why we have two of them. And I can only explain it as I move along, so bear with me. The state exchange, here is an example of the state exchange of New York. This says the New York State of Health. The thing that you keep in mind here is that the State Department, the New York State, provides this service. And it is specific to New York State. And I can't, as I said, this actual site itself is closed right now, so I cannot navigate across it. I can only tell you what's on this page. The individuals and families can go here to find out the types of programs that are good for them. If you want home care, you can go here. If you're an employer who's looking for insurers for your employees, you go here. And yes, there are brokers, insurance brokers, just like anybody who goes out on their own and buys insurance, they go to insurance broker. These are people that can tell you what's the best. They know the universe of policy, and they will be able to tell you exactly what you need to know to apply for a specifically insurance policy. And then there are sisters. This is very unique to New York, and they have variations of it in other states, but it's a beautiful thing. The other way of looking at them is as navigators. Every single county in the state of New York has a whole category of assisters they're all nonprofits. Nobody's being paid to do this. It's the Community Service Society of New York, for example. These local chapters offer services to people who are trying to figure out how to navigate the system and need to know how to sign up. Also, it says up here, languages. It's about 10 different languages this whole site is offered in. So it is very user-friendly for New Yorkers, and most states who have these state marketplaces make it as user-friendly as they possibly can to encourage people to participate. So I'm going to close out this. As I said, it's only open in New York from 9 to 9 during the day in New York, and on weekends from 9 to 1. So it's already closed here. Then there is the Federal Exchange. This is, you see this thing, this is the official site of the United States government. Basically, it does the very same things that the state exchange does. And you ask yourself, well, why do we need two of them? This is the lunacy of compromise, of what we had to do to get this thing passed. And in a minute, I'll show you, a lot of things are on here. The federal government's done the best job it could to put this thing together for people, but it's hard. And, so it's there it's the least thing we could do for people, let's put it that way, given the political climates that we're operating in. So, as I said, this is what we have. This is what the healthcare marketplace is all about. It's a gateway. It's available to everyone unless those who are getting health from their employee or Medicare. You don't need this if you have Medicare. Insurers compete based on cost and need, and it is available. There are two marketplaces, a state marketplace and a federal marketplace. Okay. Why is it? Okay. There's also, as part of this marketplace, we mentioned that the other feature of the Affordable Care Act is state innovation waivers. These are things like providing food insecurity programs to supply meals, supporting these you can get grants to support these things. Climate change initiatives, like providing air conditioners for families with asthma and helping communities prepare for extreme weather. Knowledge sharing, including provider training on mental health, social determinants of health, behavioral health grants, insurers for mobile crisis units and respite care services. You're not going to get this from the federal exchange. Medicare, after we've got that finished, okay, this is the best we can do, but now let's move on to what we want. The best possible world, if we could have it, is Medicare for all. What do we mean by it? Bernie Sanders tells us about it all the time. All Americans are covered, no significant costs, no option to keep private insurance. Taxes would increase for corporations and upper income groups, which tells you right away the chances of this happening are slim to none. The government would control prices of medical care and pharmaceuticals, and it is managed by the Health and Human Services, Office of Medicare and Medicaid Services. Anyone who's had any dealings with Medicare, the first time you signed up for Medicare, it was as easy as pie. You were astounded by how easy it is. You were astounded about how helpful people were. And even Paul Krugman has pointed out on several times, for some reason or another, national health insurance is easy to put together, and it will be easy to navigate, I guarantee it. There's also the pros and cons for Medicare for all. Citizens would automatically be enrolled, healthcare delivery would be more efficient, drug prices, costs would be reduced by 10%. And the cons, there's nothing to substantiate these cons. The important point to point out here is the Inflation Reduction Act of 2022 has already made a dent in what we mean by Medicare for all. And that has to do with the creating or managing drug prices. Just as a point of information, on the bottom here, the Kaiser Family Foundation has found that 40% of people polled approved of single-payer health care, and 62% of people approve of Medicare for all. Now, when I mentioned this streamlining the drug price negotiation process, this is something the current administration is working on. I'm using this as an example to give you an example of follow the money. We have right now this job, if you will, called the pharmacy benefit manager. This person basically is analogous to a travel agent, someone who you go to find the best flights, to find the best hotels to stay at, to know about what you can visit at a particular site, blah, blah, blah. We have this same person is used to navigate through the healthcare system or the drug delivery system. It's sort of like the Expedia for drugs. What does this person do? This person works with the drug company, goes directly to Pfizer and all the other drug companies directly. Then they go to the pharmacies and the pharmacy chains here. We're talking about CVS and Walgreens, the big people. And then they also will deal with Medicare in terms of their management of costs of drugs. They are able to manage wholesale costs, wholesale prices. And then we have this other person over on the end, and I'm sure I just threw it in here because I know about it, discount cards. After all of these things that are put into place, we have a company that pops up that's going to offer a discount card on a drug after you've already paid for your your cost of your drug has been calculated, then you can use this discount card to further decrease the amount of money that you're going to pay for your drugs. Now, the point to keep in mind with all of this, and this affects everything that we're talking about today, is that all of these sites, every one of these sites are a cost center, and every one of them has to have their beak wet. So this, in it, the very structure here, is this all necessary to pay for a drug, to provide a drug? Well, the Inflation Reduction Act says no. What we're going to do is we're going to get rid of them, and we're going to get rid of this, and we're only going to have Medicare working directly with the drug companies, negotiating drug prices in the pharmacy. It is an expectation that we will decrease the cost of drugs by 10%. This is an important notion of all the people that get involved in our healthcare system that may or may not be necessary. And these are the ones that increase the cost of healthcare, and all of these people need to get their beak wet. Is this thing going to go away anytime soon? I don't think so. The Affordable Care Act current enrollment trends are 18.6 million through Medicaid expansion, and we're going to talk a little bit more about Medicaid expansion in a minute, but 14 million more since 2000, 32 million more since 2014, and the DC reduction in insurance rates and all uninsured rate in all 50 states, and total we're talking about 45 billion people enrolled in Affordable Care Act. Add on to that the number of people who are enrolled in Medicare, and you've got close to 100 million people that are getting government-sponsored health care. Now, do you think that anybody's going to get rid of this system? Think again. Can the Affordable Care Act be repealed? It was set to expire in 2023, and all of us remember, who was it? His name is escaping me right now, sitting in the floor of the Senate, pointing his finger down, John McCain, who was the one that stopped the end of the Affordable Care Act, that it would not be repealed. One senator was saved the Affordable Care Act, and he was a Republican at that. The American Recovery and Inflation Reduction Act extended coverage through 2025. That's next year. Could it be repealed? With 13% of the population enrolled and as many as 100 million people covered by medical insurance through the government, it's possible. If a lot depends upon what happens in the election. Now we want to look at how does systemic racism interact with the healthcare system that we had. We need to keep in mind that the systemic or structural racism, whatever you want to look at, is hardwired. It's into our history. It's into our DNA as a nation. It's part of our disgraceful history, and we can't seem to get rid of it. It is enduring. It's enduring, and it is hidden. It isn't always obvious to us, and it follows what I like to call a concept of mystification. By mystification, I mean it was a concept developed in the 60s by R.D. Laing, as an existential psychiatrist, who came up with the idea of this is what happens when people are interacting with each other and they don't know what they're talking about. I know what you know what I'm talking about. I know what I'm talking about. You know what I'm talking about. But there's a meta rule that says we're not allowed to let each other know what we're talking about. In other words, we don't make overt what is covert. And that is one of the things that goes on around systemic racism. Now, remember I said there were these two marketplaces, the state and the federal, without any clear understanding of why we have them? Well, look at where the populations are located in the state. The gray states are states that only have federal exchanges. These are the states that are primarily thought they didn't care about. They had to live with the fact that the Affordable Care Act is here to stay, but they weren't going to do the least amount of effort that they possibly could to make it work. So they left it to the federal government to create the federal exchange. The other states, the ones that are green here, are states that actually created a state exchange. And as you can see, what is the breakdown of the populations in that state? You see the Latino and Hispanic populations are very numerous in the states of the West and in the states of the Northeast. These are the states that have the state exchanges. Then look at the populations of Texas and Florida. This gives you a little taste of what the population distribution is in these states. Here is a state that only wants the federal exchange, that doesn't want to get into the business of providing health insurance for its population. 39% is Latino, 39% is white, and 11% is Black. This to me is suspiciously suggestive of racism. Latino, white, Black population, similar decision when it comes to Florida. These states do not want to be bothered with, these gray states do not want to be bothered with facilitating the use of the Affordable Care Act. The same thing sort of is resembled with Black and African Americans. The populations of it's more skewed towards the Northeast. But look down here at these gray states. This is important. This is very important. The Black population makes up 36% of the population in Mississippi and 25% of the population in Georgia. Let me go back there for a minute. Yet, the state did not think it was necessary. It's a Republican governor, and a large Republican assembly and the Senate. I think it has a supermajority in the assembly. They could not pass a state exchange program. Now, if you remember, there was also a feature of the Affordable Care Act that said states could opt out of it because it was Medicaid. And it was to cover nearly all adults with incomes up to 138% of the poverty level. It was easy to apply for it and easy to get it. And let me go back to there for a minute. And as you can see, there's been a few states within the last week that have decided to include Medicaid expansion. But you could look at these states here. All of these states here are states that cover the wide swath. It's hard to look at it politically significant, except when you start to look at these 10 states that absolutely refuse to go along with Medicaid expansion. Let's look at the poverty and race of these 10 states opting out of Medicaid expansion. Alabama, 25% is African American and 15.98% is in the poverty level. It's the 8th level in the nation. This all comes from the United States Census data as of the last time census data was taken. Mississippi has the highest percentage of African American population in the country, and it is the second highest in poverty level. It is second only to Puerto Rico, which is another situation altogether, which is for another day. But so when you talk about the contiguous in the United States, Mississippi is the first, and it is one of the 10 states that has opted out of Medicaid expansion. Let's drill into Mississippi for a minute. And let's look at the demographics, again, a little bit more intensely. 51% white, 36% Black and African American, Hispanic, Latino, Asian, Native Americans. You can see that the majority is white, but it's not as significant a majority as it might be in a place like Wyoming, for example. And what about the ranking of health in Mississippi? It is 50th in the country in infant mortality. It is 45th in obesity. It is 4th in adult smoking, which I'm sure the tobacco companies would be pleased about. It is fourth in adults, 45th in obesity, fourth in adult smoking, 48th in diabetes, and 50th in life expectancy. Now let's look, what is out this healthcare marketplace in, they only have the federal exchange, okay? But that doesn't mean that health insurance companies haven't decided wanted to get into the act in the state of Mississippi and offer health insurance. And it isn't just United Healthcare or Metro Plus or any individual company. There are exchanges, proprietary exchanges that have developed to organize healthcare resources in a given marketplace. In Mississippi, a marketplace in Mississippi is managed by a proprietary company called Health Markets. And it talks about how it's going to provide you help with the Affordable Care Act, and it's going to give you all these plans, and it tells you here are the insurance companies that you can get, and it varies depending on individual cities, and it's a pretty easy to navigate site. I have no problem with this site. It looks very nice. But, who are these people? Health Markets is a company that's based in Dallas, Fort Worth, Texas, so it really has no allegiance to Mississippi. It is owned by United Healthcare, which tells you it's part of a huge conglomerate. It was taken over by private equity, so it's not even a corporation anymore. It doesn't have the Securities and Exchange Commission breathing down its neck. It is a private equity partnership of Blackstone Group, Goldman Sachs, Capital Partners, a large banking partners. This is a major money-making operation. They have a peak revenue of $568 million in 2023. So this particular marketplace, this particular service that is providing services with the Affordable Care Act, its objective is to make money. It's not to provide a service, which is what the state marketplaces are specifically designed to do. And why don't they approve of, let's say, the Medicaid expansion program? Why don't we ever get around to that in Mississippi, given the demographics that we just already discussed? Well, I'm going to, let me see if I can, is this going to work for me? Yeah. Yes. This article appeared in yesterday's New York Times. Mississippi's first serious bid to expand the Medicaid marketplace collapses. The lawmakers failed to reach a compromise. The serious attempt to expand Medicaid to the Affordable Care Act collapsed Thursday night. It had dashed any hope to provide largely free health care to as many as 200,000 low-income residents and possibly resuscitated the financially strapped rural hospitals. And it goes on. The push for Medicaid expansion was steered by Republicans in the state legislature, where the party was a supermajority, and illustrated the degree to which attitudes about the Affordable Care Act have evolved. The law, which many Republicans around the country reviled and attacked for years as a signature achievement of the Obama administration, has found grudging acceptance. All but 10 states have expanded their Medicaid program, and Mississippi is one of them. Let's look a little bit about how healthcare delivery is affected by systemic racism. These are the things I'm going to look at quickly. The geographic maldistribution of medical resources. There's racial differences in patient preferences. How does systemic racism work in pathophysiology? The economic status of people, the insurance coverage, and the trust, knowledge, and familiarity with medical procedures. This is how it works. Here is an example of what's happened with the geographic maldistribution of resources in New York hospital closings. That's where you see where are these closing happenings? They're happening in communities that are not rich in healthcare resources. They're in communities that aren't rich, period. Downstate and East Flatbush is what was on the news recently. Rose noticed me that it was not closed. That the community put in enough effort that they put a stop on the state closing this hospital. Mount Sinai Beth Israel campus on First Avenue and 16th Street. You could say to yourself, well, what's the big deal? It's right on the Gold Coast of New York, Manhattan hospitals. There's Bellevue, there's NYU, there's Cornell, there's Mount Sinai, there's Beth Israel. I mean, there's all kinds of hospitals here. Why? What's the big deal that this should close? Why? Because it's the only hospital left that's close to the Lower East Side. There are no hospitals on the Lower East Side. There used to be one hospital on the Lower West Side, which was St. Vincent's, which closed. So there's a great emphasis on wanting, this hospital serves a large population on the Lower East Side. There's still a lot of activity in the community that it isn't going to close yet, but you have to stay tuned to the news. Kingsbrook Jewish Medical Center in Crown Heights, which served a large Caribbean population, was converted to a medical village. This was the first idea that we have of, the urgent care centers. This was the original urgent care centers. They converted a hospital into an 24-hour emergency room and a clinic. But they didn't have any inpatient resources. Gouverneur Hospital is another example. Gouverneur was the only hospital on the Lower East Side, and it primarily serves a Chinese population. And this learned the hard way how to care for a particular cultural group that the dominant culture was not familiar with the dynamics of health for these particular population. We would go into, and we worked on a group, I worked on a group on Gouverneur that worked on trying to develop community resources with the School of Nursing and the School of Medicine, trying to come up with something. And they realized that a lot of people wouldn't listen to us. We would go to community centers, we'd give a presentation on health or diet or whatever. We'd have health fairs. People wouldn't come until we finally realized that, wait a minute, this population, you don't go to a mother and say, the patient is not a patient individual. The patient is the family. And unless you bring in everybody into the system the Chinese person is cared for in the context of a family, and there wasn't enough of an emphasis on this. The whole system eventually went through various iterations and finally rounded up as a skilled nursing facility, a little bit like a rehab center for the Chinese population. And then there's a New York State bill on which is looking for community input to seeking closures. It has passed the Senate, has not passed the House. This is the bill if you want further information about it. Racial differences in patient preferences. Patient care outcomes improve if provider and patient are the same race as patients. That's not always possible, but they have reason to believe that this is the case. Patients emphasize professionalism over race, this is what they found. You have to know what you're doing if any patient is going to respect you and accept you. Patient appreciate providers' cultural awareness and willingness to self-educate. Remember, I mentioned that characteristic of mystification. You are maybe a white professional, nurse or doctor or social worker, and your patient is an African-American patient who grew up in a entirely different neighborhood, may have an entirely different economic background, and you want to talk to this person about their health. And you're looking at them and they're looking at you, and all of a sudden, you realizing that there's something going on here that we're not allowed to talk about. And that is, I know that race is an issue here, and you know race is an issue here. So we're not going to talk about this issue. We're going to talk about your diet. And when you look at it from that point of view, you're missing the point. And unless the healthcare and the patients are saying, unless you address what seems to be something that's going on between us, unless you bring it out and you bring it up front, you're not going to get the patient's not going to get the help that you are basically prepared to provide. Systemic racism and patient pathophysiology. We used to think that people didn't have good outcomes because they didn't follow the rules. You know, patients, we had all this research that said that patients of various races and cultures had poorer health outcomes. They had more diabetes, they had more heart disease, they had more high blood pressure. And we had to teach people as healthcare providers about what was wrong. And, you know, this is what you have to do. You have to control your diet, you have to take your medicines, you have to come for frequent checkups. Except we were not paying any attention to what was maybe causing these diseases to begin with. And one of the things we've learned, the poorer health outcomes, racism has proven to us that the poorer health outcomes are especially mentally healthy related, and they are related to post-traumatic stress. The 1,000 cuts that come with the micro cuts of racism that happen all the time, and that builds up, and it leaves a condition of post-traumatic stress, and it expresses itself in things like blood pressure and hypertension and diseases that, if it had been addressed at appropriate time, if you ask people not what their diet is about, but what concerns them the most, you're likely to be more helpful. And we've also found that patient pathophysiology is not so much predictive of blood pressure and hypertension, it's more predictive of stress. And this is significant also for Hispanic, Latino, and Asian populations. This is a big point here. And this happened in our group when we were talking about the mistrust in the medical establishment. The word Tuskegee came up. And frankly, I thought, oh, Tuskegee. It wasn't until I realized, as I went into this data, and when I realized what we were talking about, that the output from the Tuskegee study and the Willebush study, the shadow of Tuskegee is upon us, and is specifically upon the Black and African American community. They think of this, and they don't have enough reason to believe that the healthcare system has significantly changed since that time. And I have an article here, this particular piece that you can, this is a little piece I put together on the history of the system for our benefit. You're certainly welcome to access that. And let me get rid of this. Okay. And the other thing is this article, for those who are interested in the shadow, a historical look at the African American healthcare. This is from the American Journal of Public Health, in case you are interested in looking at that. And then we have, this is interesting, and I love you to think about this for a minute. This is 2014. This is an article that appeared in Spiked. This is the online British version of about the most conservative website you could think about in America. This is like everything that you don't want to know about healthcare. And it is extremely conservative in its views, and it's reactionary and libertarian. It's like watching Fox News. Now, this article here, which is a cultural anthropologist, offers a counter narrative to the infant story of U.S. scientists allowing Black men to suffer from untreated syphilis. This person, Richard Swager, is not just some outlier nut job. This guy is a professor of cultural anthropology at the University of Chicago, and has come as using obscure concepts in anthropology and sociology, such as presentism is the word he uses. In other words, we are, by finding a problem with Tuskegee, we are re-examining it using the current marketplace concept on something that happened at a different time. Well, my answer to that is it doesn't make any difference whether it happened in 1947 or it happened today. It's the same thing. And that is something that to this day, we are finding people finding a way to find a counter narrative to what happened in Tuskegee. And please, everybody who sort of understands this, and I believe African American, Black Americans know this, and they do not believe that we have gone beyond this. And this has also shown itself in the uncertainty regarding vaccine safety. I would be if I knew about this, I would be nervous about it too. And it also is, anybody's nervous about it with the abominable way that the Center for Disease Control and the Department of Health, Health and Human Services rolled out this whole thing was a disaster. And then there's the issue of limited access. How often do people know about this? They know about it in their communities. Is anybody rolling around with a mobile van to help people to figure out what it is they need? And if you don't have the appropriate resources, how are you going to know about that? And if you don't know about healthcare very well, how are you going to know about that too? All of these things are operating for us and come into play in the mistrust of the medical establishment. Let me see. All right. Social and economic determinants of health. These are things that factor in, and we have reason to believe that these are important factors. We can add to these things ourselves as people. Healthy People 2030. This is a CDC, the Health and Human Services sends out an invitation to America to tell us what you think is important and what are the health outcomes you want to achieve by 2030. You can go to this website and you can put your 2 cents in, is what this is. Registration is now open for the next Healthy People 2000, Air Quality Matters, Improving Health. Different types of programs are put there, and it's to help people understand what is available in our healthcare system that we should be taking advantage of if we want. Nevertheless, we now know through the Pfizer Family Foundation, these are the important social and economic wealth, income and wealth factors to take into consideration. Wealth factor is having money in the bank that you can use in case of an emergency, money in the bank that you can leave to your children as a legacy. If you don't have employment, this is not going to enable you to get health insurance if it's offered by your employer, which is one of the reasons why we have the Affordable Care Act. If you need a financial assistance with housing, this is going to affect whether or not what your health is going to be like. And if you're less likely to own property, again, this has a big factor in how well off you are and how healthy you're going to be. I mean, you see all these very rich people dying. They're 95, they're 98, they're 110. You don't hear about too many people of lower socioeconomic status that are, a lot of them who are dying and they're dying at an earlier age. The effect of the Affordable Care Act on racial and ethnic minorities. This is the gains that have been discovered through the system. I believe, let me look and see what, I don't have This is from the Office of Assistant Secretary for Plan, the Healthcare Enrollment by Race and Ethnicity, 2015 to 2022. This is healthcare.gov has provided this information for you to look at. And basically it's telling you that there is gains in health coverage, and estimate 1.7 million Black and African Americans and 3.4 million Hispanics have enrolled in the marketplace in 2023. Asian Americans, Pacific Islanders enrolled 14% between 2020. And we see a similar type of Hispanic, Latinos, and Asians frequently selected plans with cost-sharing options. What do we mean by cost-sharing? Patients with cost-sharing reductions below a certain income pay less out of pocket each time they receive services. This is a benefit that people can access. Okay. I put this in because it seems to indicate to me what's more than that beyond insurance availability. if we look at, and we look at, reason why I looked at the racial differences in Medicare Advantage plans, people have to pay for this. So I looked at this as a proxy for people, African Americans who maybe can afford the Advantage plan, which means they are perhaps have more resources than people who don't. So I'm looking at this group, and what do we know about them? They're more likely to be hospitalized for conditions that could have been managed earlier on an ambulatory basis. This tells me that payment alone is not going to determine how people access the system and how comfortable they feel in accessing the system. They are more likely to use breast and prostate cancer screenings. Well, that's good to know. They're less likely to be treated for depression. Well, why not? This is not, they've got the resources to do it, and yet they can't access it. Less likely to see specialists. No difference in accessing prescription drugs. No difference in satisfaction with care. All of these variabilities here are not related to economy. What else are they related to? Can we say it has to do with race? I'm not so sure we can, but we can't overlook that as a possibility in this particular investigation. Let's look at the politics of healthcare. We're almost moving along here. I'm not paying attention to time, so I'm sure Rose will tell me if I have to move it along. Healthcare for 60% of the voters is a primary issue in 2024. Reproductive rights, primary. Entitlement program protection, important. Medicare, Medicaid, and prescription drug pricing. These are the most important things regarding healthcare that people are interested in 2024. Let's look at this abortion piece to begin with. All the pieces about it. The states that for which it is banned, the gestational limit between 6 and 12 weeks. Florida just fell into that category by recently banning abortions from 16 weeks to 6 weeks, when a point which many women don't even know they're pregnant. And then Arizona, after they implemented the 1864 abortion ban, which banned abortions for everything, the state of Arizona repealed it this past week, which apparently sanity reigns in that state. But you can see the political landscape is reflected very easily by whether or not abortion is approved or not approved, and where it fits. Let me just look at another group of people for whom that have something to say about reproductive rights. The Heritage Foundation, you got to follow these people because of what they're up to. You got to know what's happening. When you talk about, we talk about abortion all the time, but we're not focusing on the fact that it's not just abortion, it's reproductive rights. It's Title 10, which includes contraception, treatment for sexually transmitted diseases, prenatal care for low-income people. This is more than just preventing abortion. It's taking care of women. And Title 10, this is the bread and butter of Planned Parenthood. And if this doesn't get taken care of, Planned Parenthood is probably not going to exist. Other pieces, and their Heritage found these conservative think tanks think of everything. They try to get you at find out every single corner that you could sneak into that will enable you to get their point across. They want to promote anti-surrogacy positions so that all children have a right to be raised by a man and a woman who conceive them. They want to reverse Biden administration policy regarding hospitals to offer abortions in medical emergency regardless of state bans. End all fetal cell research. Undo Title 10 protections at VA hospitals for screening for reproductive health care. Just screening for reproductive health care. Bar non-government organizations from receiving U.S. aid for abortion services. We have these organizations all over the world that basically have been a sign of goodwill from America. Well, it's now, there's a caveat in what it is we're going to offer the world regarding our resources.
Okay, Marianne, you have about 3 more minutes.
Okay, I'm on the health, I'm pretty close to the end here. Good, thank you. The Paramount Health Policy Institute is another example. They want to go to Medicaid, they want Medicaid block grants. They're going to work around the edges. Medicaid block grants, business self-insuring health coverage. Well, if the federal government gives a pile of money to the states, which the federal government pays 90% of it anyway, they can decide how to spend it. And they can, I'm not confident that Alabama or Mississippi is going to spend it across the board indiscriminately, regardless of racial and social class. They also want to provide businesses self-insuring. Let the business develop its own health insurance plan. I suspect there's all kinds of things that could go wrong with that would jeopardize an equitable distribution of resources. The limit the CDC powers over public health policy. And I was going to spend a little time on this, but I don't have time for it. But I recommend you go to the CDC website and try to navigate through it. There is tons of wonderful information on it. They have just not figured out a way to make it user-friendly. And we talk about health literacy. I'm a pretty health literate person. When I went to the CDC website to find out about COVID, I could not figure it out. And if I couldn't, I would imagine a lot of other people couldn't figure it out either. So there's a lot to be said for the government's inexperience, perhaps, in dealing with a pandemic of this size and scope, but they didn't do a good job. The American Policy Institute looks for incremental changes, broadening health savings accounts. Well, you have to take a considerable chunk out of your income into a savings account to help you out. So you're really operating, it's sort of skewed towards people who are making a pretty good salary that they can afford to take their money out of their checkbook every month and put it into a savings account. Broadening telehealth flexibility for providers. Okay, telehealth is wonderful, and we all love it. I love it, it's too. But a telehealth implies that you have a computer and that you have good internet access so that you can access this person. What if you live in a rural area that doesn't have Wi-Fi? I mean, you could be in trouble. This isn't going to help you at all. The transparency for the pharmacy benefit manager. They don't want to get rid of the pharmacy benefit managers, but they want to make them more transparent. They want to make sure that the special deals that these managers made with the drug manufacturers wouldn't happen, and that they could be, and that cost of those special deals was handed down to the consumer. They want to get rid of that. They don't want that to happen anymore. And of course, I just showed you how the Heritage Foundation is gutting the reproductive health care access and provisions. The liberal agenda, build on the Affordable Care Act, insurance companies from denying coverage. Let me just go back here. The main thing that the health plan initiatives, the conservative, is repeal the Affordable Care Act. That is the goal. The health overarching goal. The liberal agenda, build on the Affordable Care Act, prohibit insurance from companies from denying coverage or charging higher premiums based on pre-existing conditions. That's on insurance coverage outside of the Affordable Care Act, because that already is built into the Affordable Care Act. The Center for Medicare is negotiating drug prices with manufacturers as part of the Inflation Reduction Act, which we already talked about, and the Medicare Drive Price Negotiation Program. The first 10 drugs have been selected for this is to treat conditions such as blood clots, diabetes. These are the big ones: diabetes, heart disease, heart failure, autoimmune diseases, and chronic kidney disease. The last one, social determinants of health. The World Health Organization has weighed in on this. Social determinants of health account for between 30 to 55% of health outcomes, and health and illness follow a social gradient. The lower the socioeconomic positions, the worse the health outcomes. And you must address the social determinants of health in order for you to improve health. Providing health care is not the only thing that's going to work. That's it. Thank you very much. Let me see. I don't know what to do now. I can end the show. There we go. I can take any questions that people might have. I want to go, I'm going to stop sharing. There's where we are. I'm going to go back to shops. Okay. Here we go. We're back to the, everybody's up there. Anybody have anything they want to say or do or want information about? Everybody's muted. Can you unmute me, people? Rose, Esther?
But
There might be-
exactly, have you,
I'm
There might-
unmuted. Rose is unmuted.
there might be
Yes, if anybody
People can
has a
unmute
question,
themselves, in other
just
words.
raise your hand. You can either unmute yourself or I can unmute you yourself. I can unmute myself. If
Okay,
you have a question, just raise your hand.
okay, got it.
I do have a question to begin with. I'm curious if in your experience as an educator, you noticed any of the information about some of the history that you've shared, if you noticed it changing while you were in that role as an educator, and if you had the experience of really providing a different narrative to your students.
Well, the last job I had, basically before I retired, was in a program that was developed to aid nurses who had associate's degrees and wanted to go back to get their bachelor's. And they were working it was only offered in the city hospitals. And that program was designed primarily to make it easy for people to get their degree. And the program was offered in the hospital. The classrooms were in the hospital, so people didn't have to travel to a university. And because of that, it set the tone for exactly how I used, for example, in the program, a lot of material from the Kaiser Foundation. One of them was the special videos of interactions between healthcare providers and patients of different cultures. And we were able to look at these videos and evaluate them. And it was inevitable that the concerns of the nurses coming off their shifts, this was a very multiracial, multi-ethnic student body, and they were coming off their shifts. It was inevitable that this was going to be discussed. All these things were discussed. And that's pretty much a part of what's happening right now. That's happening all over the place. My alma mater, NYU, we're seeing it all the time. Things are happening. There is the majority of the large percentage of the incoming classes are now multiracial, multi-ethnic. The curriculum is geared to deal with multiracial and multi-ethnic issues in relation to health. It's changed. It's true. Now, I'm not so sure it's going to change everywhere, but I know in New York City, it's changed.
Thank you, Marianne. I see David, and then Rose, did you have a question next?
No, I did not.
Okay. Okay, so David.
Thank you very much for your presentation. There was a lot of information here that's important. But I'm looking at the takeaway message that I'm getting and many other people are getting. The people who design this system rarely care about one thing, that is making profit for those in charge. So the point is, the analysis to a large degree was correct, but plain and simple, those who run the country, those who rule, they decide and they care about one thing, that's making profit for themselves. The people who own the pharmaceutical companies and many of these insurance companies are making huge amounts of money, whereas the goal
Thank you. I'm sorry.
should be to take care of the people's health.
Thank you, David. And I hear the clarity too. Follow the money is the name of the presentation.
Mhm.
Mhm,
Thank you.
mhm.
Any more questions? comments?
Hyacinth?
Oh, I
I
see.
have a, I have a question. I missed part of it when I got on, but you mentioned something about, I don't know if it's the hospital or the rehab facility. When a patient, okay, I back up. A patient came out of the hospital, went to a nursing facility. The nursing facility during the winter had some radiator issues. Patient had to go to the hospital because of the radiator and the steam issues in the room, and then went back to the same facility. Does that facility get paid by Medicare, Medicaid for what happened to the patient in the facility?
I see what you're saying.
Uh,
Well, if it depends upon what their insurance is. If they have
Mhm.
Medicare and they
Yeah.
go back in the hospital after something that was already taken care of in the last admission, the hospital will not be paid for that in all probability.
Mm.
And that's an important consideration. That is, you have to balance, that's why you have to balance the hospitals have to are making money here, this, as, you know, as David just told us. And the hospital is making money, and that's and they're gonna do whatever they have to do to make the money. And
Oh,
they will, you know, take care of you, but they will not be, they'll do what they have to do to take care of you. They can't discharge a patient because they don't have insurance. They have to take care of somebody who's come to their emergency room. And if they capture whatever they can, but that's, you know,
because
they're not going to get paid. That's their fault. If somebody, it's all in more probability the hospital's fault. If somebody is sick, is in the hospital, and they are discharged, and then they come back in the hospital the next day, something's wrong. Somebody didn't do
okay, so
their work.
does it have to be 24 hours, or it could be like if the person stayed a week and then,
Usually it's within the 3 day, I think it's usually a 3 day
okay,
business.
all right, thank you.
Okay. Well, I see my hand is
There's
raised.
things in the chat here, I don't know.
But I have a
Yes,
question in the
Excuse
meantime.
me, I don't see any questions in the chat.
yeah, I
I
just see comments, yeah, okay,
Okay. I have a question. Can everyone hear me?
yeah.
Okay. Why would you think that there are more Latinos enrolled in the healthcare system? I'm not sure what is the system than African Americans, for instance. One of the slides said something similar to that. It might not be healthcare system, but
Let me try to find where I saw that.
I think that was in the Affordable Care Act.
I would have to pull up the system to look at that, exactly where that was.
it might have been the exchange. Anyway, in the meantime, I was thinking, one of the things that we didn't bring out because this program wasn't about that is that there's racism. It seems that some of these states like Mississippi, they're inclined not to accept the expanded Medicare um, because it may help African people, but white people are suffering as a result. And I'm just wondering when they might realize that, when that might occur, that, and those people who are not of African descent, recent African descent, are going to rise up and demand more.
I don't know specifically the answer to that, but I would think that nobody wins in this situation. If you're, the framework is, it's all about the money. It's all about the money for white people as well as black people or Latino people. It's just equal. The distribution varies. And the distribution is mediated by racism. And, but for the most part, we're all in this together, and some more disenfranchised than others.
Right. Okay, are there any more questions?
I have one other question.
Yes,
Okay.
guys.
In terms of nursing home and rehab facilities,
Yes.
are there regulations on them on the way they treat their patients? What goes on into the facility? Like a patient going from the hospital to the nursing home and end up with a decubiti, and they have to use gauze to pack it.
Well, that is
Is that the facility responsibility
yes, it
or
is.
Medicare?
Wherever they developed it, it's the facility's responsibility to deal with that, and that shouldn't happen. That is a sign of bad care. And
Yeah.
you don't want, let me just tell you, you don't want, the one thing a hospital or a healthcare facility does not want is the Office of Inspector General of Medicare showing up on your doorstep. They take no prisoners, they ask all the questions they want, and they can close you down. They can cut your funding, they can do all kinds of things to you. That's one good thing about Medicare. And they know when they're in trouble. And they know if these things are happening, that there's something that, yes, it is reportable. Oh, you could call up you literally can call the Office of Inspector General. You can literally call them.
Thank you.
Thank you. Thank you, Marianne. And I see
Okay.
Teresa's hand up.
You're muted.
Oh, yes.
I'm
Thank you.
sorry. I'm sorry. When you mentioned that there are 10 states, I think you mentioned that still have not accepted Medicaid expansion as part of the Affordable Care Act.
Yes.
I guess my question is the reason for that, and this relates to Rosa's question, because I thought that the partnership that exists between the state and the federal government to provide Medicaid gives them an argument not to accept the expansion, because they would have to put money
Right.
into the program in order to offer the service to their residents.
Right.
Is that correct? So
That's right. Yes, they have the right. Yes.
Right. In terms of the white population in particular, not signing on to, encouraging their state to expand Medicaid coverage, the argument is that this is going to cost them. Is that correct?
Yes.
Unnecessary money that perhaps other resources should be used to provide health care for those families that would fall under that category.
That's you've got it there, is whether or not we want, but we're talking about a large percentage of population here that is in a minority population. I mean, this is a national disgrace. Mississippi is a national disgrace.
Yes, and it always has been, but
Yeah.
I just
And
wanted
in that
to
regard,
mention that that's their argument. It's always about the money, and that the Medicaid expansion would not come 100% out of the federal budget. And so the states themselves have to put in money when they accept it, and they don't want to.
Right.
So,
Now,
they make their usual arguments against it.
okay. If I have two things that I want to bring up before we leave. And
Well, we're not quite ready to leave it.
okay, there's two
had
things
a-
I have to say yet. Okay.
Okay, okay, quickly, because then I want to go, we had said that we would let Brother David say
Sure. Okay. Yeah. Okay.
something.
The one thing I wanted to just bring up is that our a small group has started up just about 3 people got together. It's not really just, it's sort of amorphous group at this point, to put a program together for the church on Medicare. And we need about 3 additional people who might be interested in putting something like that together. Janet sort of spearheaded getting people together, and Sheila Kaminsky is a person who's sort of become the point person. Anybody who's interested can contact me directly, and I can give you further information on how to get a hold of Sheila. And if anybody's interested, just let me know, or let Janet know that you're interested, and we can participate in, get this group going together. We just want to put together
Yeah,
a program on
okay,
Medicare.
okay.
Now, there's one
That
other
was,
thing.
okay, that was not related to this program, so would you
No.
hold that? Now, because David had wanted to say something very briefly related to the Medicare issue, I mean, to healthcare issue.
Right.
And I would, just to give his point of view, but David, very briefly, and how it connects to what we're saying, if you can do that.
It's, to me, I've listened to all this information. It's important to people to know these things. But to me, healthcare should be something that every citizen should have in the country, and not dependent upon separate insurance industry. And also, healthcare should involve things that are not dealt with, and that includes nutrition and lifestyle. Should be part of the healthcare industry. So if I were in that position, I would include teaching doctors about lifestyle in terms of, things like drinking alcohol, that's a health issue, and good nutrition with correct eating and not eating junk food. So in addition to all the things that have been discussed already, I would include nutrition and lifestyle changes, and as part of the regular healthcare industry that would not include private insurance companies and would serve all the people regardless of income.
Okay, thank you, David. Dana, is this a question related to healthcare?
Yes, of course it is. That's what this is. This seminar is on healthcare. One of the big areas of lack of healthcare right now is mental health. Mental health hospitals have been closed all over the country, and that means that more and more people cannot even get a diagnosis, let alone treatment for mental health issues. And that subsequently affects housing, because I'm a licensed social worker. I worked for the state of New York Office of Mental Health. And I remember we had all kinds of programs that provided supportive housing for people with long-term mental health issues. Those people are out on the street now, or on the subway sleeping, or endangering others, and are being hurt by other people. And I'm wondering if, Marianne, you had any information on this issue, on what is it that's restraining us from providing mental health care. Also, I understand there's a shortage of social workers. I'm getting a lot of a bombardment of emails regarding need for more. I'm a social worker, but I'm already working. I'm 77. I'm still working full time for the city of New York, but I'm not working as a social worker. But there are many, apparently, lack of hiring process is very restricted now.
Well, that was part of the issue of the Affordable Care Act, is what's the essential plan? What are the features of the essential plan? You have hospitalizations, outpatient care. Part of that was mental health services. But a lot, as you're saying, Diana, you still have to have the structure to provide the mental health services in place. And I think the system realized that there wasn't enough. And one of the places where they saw that this could happen, if you remember, the innovation section, where as if people saw that something needed to be developed that we just don't have. We just don't have the structure in our system to deal with mental health issues. We just don't have it.
We used to have it. What happened?
Pardon?
We used to have it.
We used to have it, right, but we don't
Yeah,
anymore.
not very many years
And that is, at least the Affordable Care Act does have a piece of there that says that mental health services have to be provided. And if you go on the exchanges, you will find information about it. But I'm not sure how comprehensive that is, how effective that is versus if you try to get your insurance through Aetna or whatever. But most of the companies don't provide a great deal of insurance for mental health care. The system is not easily fixed. I think the only thing that was recognized in that was in the innovation section of the Affordable Care Act. That's the only place I could find it that was of any great significance.
Interesting.
Well, I would just add to that, the people have to make a demand and for these things to happen. The people have to have the will and make the demand for better services for the mentally ill. And I think you're right on time. It's
Yeah, Diane, you're right on
it's
it.
extremely important.
Mhm.
I cringe when I see homeless people on the street, and what is the solution? But something we need to have this dealt with.
Okay.
Okay, we're gonna run over time.
So exactly,
Thank
go
you.
ahead.
Thank you.
I have
Yes,
one other announcement.
No, wait a minute, Marianne. Faye has okay, let's do this in order. We're gonna finish with talking about healthcare, then announcements, and then closing. Okay, so anything else dealing with healthcare? Okay, Marianne.
It's sort of healthcare. I'm thinking, the problem of Mississippi just stays with me. And General Assembly is coming up of UU. And there are 4 UU churches in Mississippi. There is a workshop at the General Assembly on organizing for health. And I'm wondering whether someone, and this is all online stuff, that we could not use our association as a UU to have some influence on providing some help to this forgotten state. I mean, I'd be prepared to work on that. I really
Oh.
would.
Oh, you mean the mental health issue?
That's exciting, Marianne. Let's talk about that
mean,
more.
Yeah, I mean, it's not just a mental health issue. It's not, I'm not specific. I'm talking about health, period. Mississippi is a national disgrace in terms of health.
Thank you.
Yeah.
And especially from terms of racial segregation and exploitation.
Okay, so I think Faye has some announcements.
Kudos, Marianne. And on Saturday, May 18th, those of you who didn't get a chance to share stories or express your views, Marianne is willing to continue the discussion at our regularly scheduled Anti-Racism Action Group meeting chaired by Rose Creighton. So that's Saturday, May 18th, not the 11th and 12th, which is Mother's Day weekend, but May 18th. And the announcements upcoming on September 14th, we will have a program from 2 to 3:30 on human and environmental rights. And on October 19th from 2 to 3:30, both on Zoom, we'll have the final program of the year on immigration, triumphs and challenges. So we hope you will join us. Thank you.
Okay, well, thank you all for coming. It's been an excellent presentation. Thank you so much, Marianne.
Thank you.
Marianne,
Thank
wonderful.
you. Appreciate it. Thank you.
Thank
you
you
so
for
much.
the information.
Okay.
Thank you.
Bye.